Welcome to the Heart Valve Society interview series. My name is Dr. Jeffrey Silberger from the Icahn School of Medicine at Mount Sinai in New York. In this series, we connect with experts in our own field of heart valve disease and discuss topics of interest, and share valuable insights. Before we start, I'd like to remind our viewers that the Heart Valve Society membership offers many benefits and opportunities, so please visit our website and learn how you can get involved. We're also pleased to announce that the next annual meeting of the Heart Valve Society will be taking place next year in Chicago from April 15th to 18th. And now it's my great pleasure to introduce our guest for today's interview, Dr. Mark Sherrod. Dr. Sherrod is a widely recognized expert on hypertrophic cardiomyopathy, and he's also the director of the HCM program at NYU Langone Hospital, as well as professor of medicine at the NYU Grossman School of Medicine. Good afternoon, Dr. Sherrod. How are you?
I'm great. Thanks so
Great.
much for the invitation, Jeff.
Absolutely. Mark, I wanted to start by taking, say, a 30,000-foot view of hypertrophic cardiomyopathy, stepping really far back. This is something you've written about a good deal, and that is the development of the heart loop and how, unlike the RV, which has an inflow and an outflow tract at opposite ends of the chamber, the left ventricle, cause of the looping, um, creates a milieu that kind of creates a perfect storm for hypertrophic cardiomyopathy. I wonder if you could expound upon that. Hopefully these graphics will be of some use to you.
Thanks, Jeff. So there wouldn't be any outflow tract obstruction if the heart didn't have to um, have a loop in it, um, such that flow makes a 180-degree turn as it traverses the LV. So from the inflow to the outflow tract, the blood has to turn around. And as it does, if there's any perturbations of the two parts of the outflow tract, the mitral valve and the septum. If 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 there's any anatomic abnormalities there, it sets the heart up for the development of obstruction. Um, and this happens this loop happens in all vertebrates, and um, it's one of those inherent things um, that occur that evolution hasn't weeded out. Mainly because patients with HCM can still reproduce. So there's no selective pressure to get rid of this potential abnormality. Um, so here in the upper left, you see the loop and you see the close proximity of the flow to the mitral valve. And in the lower picture, you can appreciate that the flow has to, in obstructive HCM, has to move around the septum so that after it gets around the septal bulge, it's coming from a relatively posterior and lateral position such that it hits the mitral valve from behind and sweeps it into the septum. And so this is the flow drag understanding of LV outflow tract obstruction, which is very distinct from the old notion of the cause of LV outflow tract obstruction, namely that there was this thought that it might be due to a Venturi effect or high flow velocities. But with many studies, um, we and others have shown that, first of all, SAM, systolic anterior motion of the mitral valve, begins when velocities are very low in the LV outflow tract at a time when there are no high velocities. And second of all, that the angle of attack is is high between the mitral valve and the flow that it hits it from behind, such that there's such a high angle that drag are the dominant forces that that cause SAM. And this has implications,
Mhm.
which maybe we'll talk about later. But the most important implication is that if the surgeon just operates on the outflow tract and widens the outflow tract, that won't solve the patient's problem because um, one has to do the so-called extended myectomy and extending the resection all the way down to the level of the papillary muscles to redirect the flow anteriorly away from the mitral valve, allow it to escape from the left ventricle without catching the mitral valve. And this extended myectomy is now the accepted operation and is um, widely applied and avoids the early failure of the operation that was.
Mark, I have some slides that we can look at a little bit later, perhaps when we
Yeah,
get into a more extended discussion on the therapy. But I wanted to pin you down on a couple of things you mentioned. You were talking about how the septum, the reverse curvature of the septum, redirects flow so that it enters the inflow tract and
right.
therefore sweeps up and hits the mitral leaflets. Is reverse septal curvature unique to hypertrophic cardiomyopathy? I can't believe I don't know the answer to that. I must read 1,000 echoes a day. But I don't think we see this ordinarily, other than in the setting of HCM.
So are you you're asking really whether we see this
Yeah,
protruding septum
I would
elsewhere?
imagine the protruding septum and the reverse septal curvature that
Yes,
goes into the alpha tract is what's causing the abnormality because it's
yes,
redirecting flow.
yes.
Um,
Right. So
well,
so it
yeah.
turns out that you could have, well, it's a complex question. Let me answer what's very interesting first, which is that you can have a septal bulge and not have obstruction.
Mhm.
You can have a septal bulge like this and not have obstruction. And the reason that that can happen is if is that there are other um, anatomic abnormalities that need to be present for obstruction to occur. First of all, there has to be leaflet slack. There has to be um, um, a slack in the valve to allow it to move. If the chordae and the papillary muscles keep the mitral valve completely still, there's not going to be any SAM. And then the second um, aspect of this has to do with the mitral valve being anteriorly displaced in the LV cavity. So yeah, you can have non-obstructive HCM with a septal bulge without obstruction if those other two characteristics are not present. That is, the slack and the mitral valve anterior position.
So we
Um,
two
but
two
but I think that septal bulge like this kind of septal bulge, this asymmetric septal hypertrophy is pretty much a feature of patients who have HCM, and that this reverse curvature is is unique to obstructive hypertrophic
so we
cardiomyopathy.
kind of have two
HCM in general.
buckets of abnormalities that we're talking about, that will cause one, the septum, and then independent of the septum or even with a normal septum, you're saying that a long leaflet will interpose itself into the ejection flow stream, as we
Right.
see the diagram here. Um, if in the course of reading echoes daily, what single number could we use to say that there's increased leaflet length? If
Aha.
so, just to make it easy for us when we're
Sure.
reading, what sort of numbers should we be measuring? Which scallop what view should we be using when we make that measurement also?
Yeah. Thank you. That's really important. So we make the measurement we make is as shown here from the tip of the anterior leaflet to where the non-coronary cusp of the aortic valve inserts into the intervalvular fibrosa. So that length in the normals, which you can see on the left-hand side, in normals is 2.4 centimeters, and anything more than that substantially more than that. I would say upper limit of normal would be about 2.9. And of course, we have also done these studies correcting for body surface area, but for the average sized person, uh, 2.4 centimeters in length is the normal anterior leaflet. And you can appreciate that in obstructive HCM, the anterior leaflet is much longer. Again, on the left in the upper left-hand corner there. In obstructive HCM, the average leaflet is 3.4 centimeters length. I think that the most important single measurement for understanding both the anatomy and the pathophysiology is the so-called protrusion height. And you should all look for this abnormality because the normal mitral valve coapts very close to the um, annulus, about 1.3 centimeters above the annulus of the mitral valve.
So that would be, say, right around here. Couldn't you use some
Exactly.
numbers for you?
Right. Exactly. And we measure this in the three-chamber view because the three-chamber view, both on echo and on CMR, is best seen on the three-chamber view.
Another question.
And so
Free
just
off.
let me finish. So the protrusion height is double that in patients with HCM. And this is important not only because of the abnormality and identifying the abnormality, but it enables you to understand the pathophysiology. Because that protrusion height is so high, it sets you up for the mitral valve being caught by the flow stream. The mitral valve protrudes into what is almost always a small LV cavity. So the mitral valve is large and the LV cavity is small and it protrudes into that small LV cavity, and that's why you get obstruction.
Just a technical point about making the measurement. You had mentioned that you measure from the base of the non-coronary cusp, as
Yes,
opposed to where the hinge is
yes,
of the anterior mitral leaflet. And why
yes.
do you do that?
Because it's much easier to identify where the aortic cusp is, where the
We're
non-coronary
actually
cusp
adding
is.
a little bit to the measurement for the sake of
Yes,
reducibility.
yes. You want it to be a reproducible measurement, and this is it's very easy to make this measurement.
So we've been talking a good deal about the ejection flow stream. Um, uh, Um, and I know you've written a fair amount about the pathology of the flow stream impacting upon the leaflet repetitively. And I was wondering if you might, amplify on that. Here are some reproductions from one of your papers, pathology paper. And I wonder if you might flesh this out a little bit for us.
So we're talking about the pathology now, huh?
Yeah.
Okay, so I think you can all see on the right-hand side the red leaf, the red arrow is pointing to it to the residual leaflet. So this, the same doctors who identified SAM at the University of Rochester in New York, um, Dr. Shah and his colleagues also identified the residual leaflet. So SAM was discovered as the cause of obstruction by these doctors at the University of Rochester. And so the residual leaflet is that portion of usually the anterior leaflet that protrudes past the coaptation point. And this is an important piece of tissue because you see the rest of the mitral valve is bounded by the LA LV pressure difference or the LV LA pressure difference. And that holds it pretty much in place. That is because it's bounded by the LV and the LA pressure difference. By the residual leaflet is free to move in the LV because it does not have a pressure difference on either side of it. It doesn't have a large pressure difference on either side of it. So the residual leaflet moves very easily like a leaf with the flow in the LV. Let me say that again. The residual leaflet moves very easily with the flow in the LV because it's not bounded by the LV LA pressure difference. And it is very important, you'll see later on in the repair of these patients' pathology surgically, um, and it often participates in SAM. Um, and Our colleague, Dr. Swistall, invented the residual leaflet excision, the RELEX operation, residual leaflet excision, to deal with the residual leaflet. And we said, well, if we're getting this tissue, then maybe we should look at it under the microscope and see what's going on in there, because that maybe that would give us a clue as to why the mitral valve gets longed in the first place. We know that mitral elongation is an intrinsic part of the HCM pathology. It occurs in both non-obstructive HCM and obstructive HCM. It appears that at least the initial mitral elongation is genetically mediated because it can occur even before the LV becomes thickened. But then after the residual leaflet gets long enough and protrudes into the flow stream, um, we have pathological evidence that it gets beat up by the flow. With every beat of the heart, the LV is pushing on this leaflet and dragging it, pushing it into the septum. And there's abnormal pathology that we can see and that we've published in a paper that um, uh, you know we published about 4 years ago. And in that paper, we distinguish between normal architecture on the left and the obstructive HCM architecture on the right. And you can see that in the residual leaflets with obstructive HCM, the collagen and elastic tissue are disrupted, and it looks as if the fibers have been broken. Um, and this is because of this incessant movement and, if you will, trauma to the mitral valve that occurs over time.
Does this trauma lengthen the leaflet over time?
Yeah, yeah, I think it does. There's kind of a mystery about why obstruction might develop in a 70-year-old. So the question is, Doc, since I've had this problem all my life, why did I get sick just a year ago? Why did I suddenly get short of breath? And we believe it's not because the septum has gotten much thicker between 60 and 70, but we believe it's because the mitral valve has become stretched because of the push on it.
I see. Just taking a step back, the question arises, why is the mitral valve involved at all in hypertrophic cardiomyopathy? Certainly, valve tissue doesn't express um, any of the genetic defects that we see in myocytes in sarcomeric harboring tissues. Why the leaflet? Why is the leaflet long?
Right. So I think that we have, I think, the answer of what happens in patients who ultimately come to surgery and what happens to them towards the end of their course, or the course that's just before the operation. I think that part of the leaflet, um, just gets stretched. Um, but what you'll see from this, from what I've said so far, that we're not actually looking at the part of the mitral valve um, that is, if you will, more proximal or more closer to the annulus, because we don't have access to that tissue. And so we did some rather complex immunohistopathology on these leaflets that we excised, and we found no explanation for why the leaflet elongates to begin with. And I think that's still a mystery. You've put your finger on a mystery. Why should the mitral valve be involved at all? Um, and it's not known.
Let's move along then, Mark. And perhaps address some of the issues relating to mitral annular calcification and SAM and outflow tract obstruction. This is from a paper which you um, asked me to look at a little while ago, written by you and one of your colleagues, about the effects of mitral annular calcification on SAM and outflow tract obstruction. I wonder if you might be able to flesh this out a little bit for us.
Right. So this was work done by my colleague Danielle Macera at NYU. And it's been known for years that MAC is common in HCM. But we found that uh, bulky MAC that acts like a space-occupying lesion in at the mitral annulus is more common in obstructive HCM. So in panel D there, you'll see um, the normal, relatively posterior coaptation of the mitral valve, which is tucked in well out of the way of the flow stream. It's relatively posterior. But as I've mentioned, a common denominator of obstruction is that the mitral valve is anteriorly displaced, allowing it to be caught by the flow stream. And we devised a measurement called the displacement area, or displacement, or the offset from the posterior wall to the coaptation point. This offset, which measures how far the mitral valve coaptation point is away from the posterior wall. And what we found was that when you have bulky MAC, like is shown here, the whole mitral apparatus is displaced anteriorly by this bulky MAC. And so the understanding is that HCM causes MAC, but MAC predisposes to obstruction. And the way it predisposes is by this offset by this anterior displacement. And these distances were very statistically significant in the patients with obstruction.
Now, for the Mac to do this, I would imagine you would get no offset if the calcium were to accumulate solely on the atrial and ventricular surfaces of the posterior leaflet, because there would be no displacement, no offset. I would imagine, as in the diagram that I have here on the left, that the Mac would really have to invade the substance of the leaflet in order to displace it inward into the cavity.
Yeah,
Um,
it grows anteriorly as well as laterally. Yeah, it definitely does that. We actually did the MAC offset distance shown in B, and
mhm,
that offset distance is increased,
yeah.
especially in patients with obstruction.
Okay. This is also from what some of your previous work. Um, uh, and here we're talking about a measurement we don't usually make, but one of interest nonetheless, and that is the aortomitral angle. And I was hoping you might be able to flesh out how this alterations, decrease in this angle can lead to outflow tract obstruction. And just in general, what affects the aortomitral angle?
Well, it does get narrower over age, um, but it's particularly narrowed. Um, the angle decreases, and what it tends to do is it shifts the way the annulus sits and relative to the aortic annulus, and it tilts the mitral valve into the flow stream.
Mhm.
And that tilt of the mitral valve into the flow stream allows the angle relative to flow to increase. If you will, it presents a wider area to the flow stream and um, increases the flow drag and the pushing force on the valve.
So we might add this then to the list of reasons that you can tell the 75-year-old patient why he's been asymptomatic for 75 years and suddenly now symptoms are appearing, and maybe because not only did the leaflet lengthen from trauma, but also the aortomitral angle presumably narrowed as well.
Yes.
Okay, let's move along. Uh, to another cause of SAM and outflow tract obstruction, and that is anterior displacement of the papillary muscles. And I have a couple of echoes, a normal echo and an echo with anterior displacement, and a diagram to go with it. I wondered if you could shed some light on this for us.
So I think you're highlighting here an important point, which is that um, any specialist in HCM has to be a specialist in the mitral valve because every part of the mitral valve, from the valve itself and the leaflets to the location of the valve and its angle relative to the aorta, to the chordae, which you'll probably discuss later, to the papillary muscles, all participate in obstruction and can um, lead to um, problematic symptoms through obstruction. So yeah, you have to look at every level. And so I guess on number C, you're showing the relatively normal location of the papillary muscles in the left ventricle, which is well below the halfway point in the ventricle. While in panel A, you're showing this anteriorly displaced papillary muscle here. And this is extremely common. And this abnormality was first shown by Jiang, Levine, and Wayman in one of their seminal articles about HCM. That is anterior displacement of the papillary muscles. And um, what this displacement does is it, first of all, decreases the restraint on the mitral valve. Because, if you will, there's a tug of war going on between the displacement force of flow and the restraint on the mitral valve that's applied by the papillary muscles and chordae. If there wasn't restraint on the mitral valve, then it would just fly out the aortic leaflets. There has to be restraint. And SAM is a dynamic equilibrium. The mitral valve is in dynamic equilibrium between the pushing force and the restraint on it. And by anterior displacement of the papillary muscle, one is decreasing the posterior restraint on the mitral valve. And by doing that, you're allowing SAM to occur. So that's one way that the papillary muscle displacement causes SAM. And the other is that um, by this anterior displacement of the papillary muscle, the mitral valve itself is located more anteriorly in the LV cavity. And I think you've shown this on this nice picture of B on the bottom. And you can see that the coaptation point is relatively anterior because of where the papillary muscles are displaced. And you've also shown that there's slack in the chordae, um, which allows the mitral valve to move, but also decreases the restraint on it.
Mark, we know that accessory papillary muscles are quite common in HCM. Does anterior displacement of these accessory papillary muscles have any clinical relevance? Do they have an adequate chordal supply, or are they just kind of isolated muscles that just lie there and without good chordal attachment to the valve?
Well, one has to look and see. Sometimes it's only the surgeon who can give you the answer to that question after direct inspection. But um, if if the mitral valve, if the papillary muscle is displaced the way it is in panel A there, usually that sends um, chordae to the mitral valve, and there's going to be less restraint on the valve because of that anterior displacement.
Okay, let's move along. Um, Here's another abnormality that we can encounter, an anterior apical displacement of the papillary muscle. And how might this play into outflow tract obstruction?
Right,
We seem to be bumping up against a recurrent theme here.
right. So um, this abnormality um, was described in several papers. And I had the opportunity to ask the question of one of the authors of these papers, how does the apical displacement contribute to SAM? Doesn't make any sense how apical displacement would contribute to SAM. And there was no good answer. And the reason is that it isn't the apical displacement that predisposes to SAM, but as you've drawn it, it's the anterior positioning, and in the echo on the left, panel A, the medial displacement that brings the mitral valve coaptation into the flow stream. So these apically displaced papillary muscles are often anteriorly displaced papillary muscles. And so I would put apically in parentheses and put the word anterior in bold.
I see. Now we come to we've talked about the papillary muscles. We've talked about the septum and their roles in causing salmon outflow tract obstruction. And here's I found a really fascinating cause of outflow tract obstruction, and that is related to short cords. I wonder if you could amplify in this.
So yeah, so so this is from a paper by Ferrazzi, who practices outside of um, Milan, and the these are chordae chordae that are often short and thickened, or actually it could be a papillary muscle that's short and thickened, that inserts directly into the middle of the enteromitral valve leaflet and tense it towards the septum. So the white arrow on the far left here shows that the mitral valve is um, is being, if you will, tented up or displaced towards the septum by this shortened chordae. And this is often under tension and um, predisposes to SAM, such that, and then if you look at the picture on the right-hand side, the lower picture on the right-hand side, you can see the in number A, preoperatively, you see that it says fibrotic secondary chordae inserting directly into the middle of the anterior mitral valve leaflet. And then the surgeon can actually cut these if they don't participate in the support of the mitral valve leading edge. So as long as the leading edge is not supported by these chordaes, you can cut them. And you can appreciate the difference in the mitral valve configuration between A and B. First of all, it's no longer being tented anteriorly under tension. And second of all, um, the mitral valve now is allowed to drop down posteriorly. Now, even before this paper from Ferrazzi, our group had published the notion of resection, plication, release, the RPR operation, resection, plication, release. And um, the release part of that was, often involved release of the um, chordae of the mitral valve and allowing it to drop down. So here on the left, on the upper panel, you can see the drag forces pushing on SAM, pushing the mitral valve. And you can see that the papillary muscles are drawn here as if they're sort of glommed onto the anterior wall anteriorly there. And an inadequate resection, there's still that that bulge of the papillary of the septum there, so that the flow still has to get around it. And this is why the initial Moro procedure sometimes failed, because the flow still has to get around. It catches the mitral valve. And the next one shows the extended resection, allowing the flow to go anteriorly away from the mitral valve. And then in the bottom panel, you see that the papillary muscles have been released from the wall of the left ventricle, which allows the whole mitral valve apparatus to drop down. And this is accomplished by what you see in very nicely shown, Jeff, in the top picture here, where the myectomy excision is extended into the lateral wall here, and that releases the papillary muscle. As part of the release procedure, any chordae that are causing the mitral valve to be displaced into the outflow tract are also cut. Um, so portal cutting and release are kind of all of the same um, feature. They all allow the mitral valve to drop down in the LV cavity out of the flow stream. So, you know, the major effort of the surgeon is to separate the inflow and the outflow portions of the left ventricle, to separate the inflow and the outflow portions of the left ventricle by the myectomy, which gets the flow anteriorly, by the release that allows the mitral valve to drop down. And here now you've come to working directly on the mitral valve. So um, the first operation that was done to address the mitral valve was by McIntosh and his colleagues at the NIH, and that's in panel A there. And he devised this vertical plication procedure, um, which is like, if you will, a tummy tuck to the valve to take out its redundancy. And my colleague, Daniel Swistel, did that for several cases, but he didn't like the way the mitral valve got bunched up, especially if the plication was extended to the leaflet margin, because bunching up the leaflet in that way actually presented more of a target for drag. And so he altered the procedure to the horizontal plication shown in panel B, where um, in the middle of the anterior leaflet, um, uh, 2 to 4 millimeters of mitral tissue is plicated, shortening the valve and stiffening it. It shortens the valve and stiffens it. It's a little bit like reefing a sail um, uh, to decrease the force of the wind on the sail. It decreases the pushing force by decreasing the area, and at the same time stiffens it. More recently, he's taken a more direct approach to this, um, which is shown in the upper right-hand panel. When there is a residual leaflet that does not involve closure of the valve and coaptation, and if it is held in place by these curlicued chordae, you can see the black arrow pointing to the curlicued chordae. This is a part of the valve that doesn't in any way participate in closure, and can be taken if there's adequate chordal support on either side. Um, and so obviously this involves identification of the residual leaflet by echocardiography and transesophageal echo in the OR. And once the residual leaflet is identified, it can be um, taken. And this is what the pathological specimen looks like, with the cut surface on the bottom and the chordae, these redundant stretched chordae on the top. So this is our preferred technique at NYU now for patients who have large residual leaflets. And some of these leaflets are very impressively long. So sometimes you'll have an intro leaflet that will measure 3.5 to 4 centimeters, roughly a centimeter to a centimeter and a half longer than normal. and also with a residual leaflet that can be anywhere from, say, 0.3 centimeters to 1 to 1.5 centimeters long. So the residual leaflet can be very, very long. And again, this is the specimen where we found that those disrupted collagen and elastic tissue fibers when looked at under light microscopy. And this has proved to be a very useful operation in patients who have very long mitral valves. Now, more and more, we're being referred patients who have relatively normal septal thickness, but who have SAM and mitral septal contact because their mitral valves are very long. So in patients with relatively normal septal thickness, it's the mitral valve that's the main actor in the SAM. And one has to address the mitral valve directly if one hopes to rid the patient of systolic anterior motion.
So we've kind of come full circle here from talking about septal abnormalities, papillary muscle abnormalities, chordal abnormalities, and how they're approached surgically. I would be remiss if we didn't at least spend a little time talking about the issue of SAM causing mitral regurgitation. And talk about a little bit about its pathophysiology and how this is addressed.
Right. So the important thing to remember is that if the patient has SAM and moderate or even severe mitral regurgitation, that if one alleviates the SAM, either surgically or medically, that the mitral regurgitation improves, sometimes completely. If the patient has structural abnormalities in the mitral valve, like prolapse or even MAC and a completely stiff posterior leaflet, then those patients might still have mitral regurgitation after the SAM is alleviated. So I'm making the distinction between functional mitral regurgitation, which is due to the SAM, and structural mitral valve problems due to anatomic abnormalities like prolapse, a flail, or MAC. And you have to look at those valves and assess in your mind's eye, what's that valve going to look like after we alleviate the SAM? That's what you need to do.
Mhm.
So here you've drawn some nice pictures, and you've made the distinction between a long, untethered posterior leaflet where the MR can move along with the anterior leaflet when SAM occurs, and those patients have relatively mild or moderate mitral regurgitation, as opposed to patients where the posterior leaflet might be short and not long enough to move along with the anterior leaflet, with a short coaptation zone, the way you've drawn it, or if they're restrained because of some calcification or stiffening, those patients, when they have SAM, will develop more severe mitral regurgitation. And you really sometimes don't know um, how the mitral regurgitation is going to respond um, until the SAM is alleviated. Sometimes you don't know. Sometimes you have to alleviate the SAM to get a feeling for whether the patient will continue to have MR. But I guess another important message here is that we don't replace the mitral valve in unless there's severe structural abnormalities, unless there's severe prolapse, severe flail, or posterior leaflet calcification due to MAC. So every effort is made to repair the valve as opposed to replacing it. And that's because you're always better with your own native mitral valve than you are with a prosthesis.
Looks like the clock has caught up to us. Thank you for a very, very interesting discussion, Mark. Is there anything that you feel that needs to be emphasized that we might not have talked about up until this point?
I think we covered it. I think that addressing these valves is, takes some experience, especially on the part of the surgeon. I think that he has to be prepared to operate on every level of the mitral valve, and he has to do it in partnership with the echocardiography team, because um, the abnormalities are there to be seen by experienced observers.
It's clearly this is not surgery for the faint of heart. It really requires a specialist who is addressed, who's spent a good deal of his career working on these types of valves. Um, Clearly, this is not something for the general cardiac surgeon.
Right. But I want to emphasize that it's really 100% learnable. Um, it just takes some effort to understand the various anatomic abnormalities. And um, by operating both on the mitral valve and the septum, you're given some insurance of having a good result. If you just do one or the other, the patient might continue to have either obstruction or MR. But if you operate on both together, the results are often additive and highly satisfactory.
Thank you, Mark. I learned a lot today. It was a fascinating talk, a fascinating disease. It's not my area of expertise, but I've always been very intrigued by HCM. It's a lot of pathophysiology to be learned, a lot to learn about the mitral valve. And I've enjoyed this time that we spent together. I just want to say to those who have tuned into us that we look forward to having you dial in regularly. These interviews are ongoing throughout the year. And thank you for your time, and we look forward to seeing you again. Thank you very much.
Thanks, Jeff.
Yeah, thank you too, Mark. That was interesting.